Good morning, everyone, and I am delighted to welcome you to our live webinar, Rare Diseases in Ireland and the EU, Finding Innovative Solutions for All. I'm delighted to initiate this event and bring really great key stakeholders together and experts to discuss this topic, looking at both the Irish and the EU perspective. I want to really welcome so many people to join us this morning. As it underlines the importance of this issue at both the national and European level. And I would like to acknowledge the presence of so many patient organisations, including Rare Diseases Ireland and the PKU Association of Ireland, amongst others, as well as representatives from the Commission and the Irish state agencies and many other clinical groups. I'm delighted that so many colleagues from the Oireachtas and councillors have signed up for this webinar today. So to all of those joining, you are very welcome indeed. We're going to hear opening remarks from each of our speakers first, and then we will have a panel discussion. You can follow the debate online on the EP in Ireland Twitter page. Please use the live chat function at the bottom of the screen, as usual, for questions to the panel. And I do have to remind everybody that this webinar is being recorded. So why this event and why now? I decided to organise this event in conjunction with the European Parliament Liaison Office in Ireland, and let me thank their staff right at the beginning, and particularly my own staff member, Conor Glynn, who has really done a huge amount of work for this seminar. I really want to thank him very specifically because there's a lot of work involved in it. But the reason we're going for this discussion at this point in time is because the inclusion of a commitment in the EU Commission work programme for 2022 to revise legislation on medicines for children and rare diseases. MEPs also called on the EU Commission to present an EU action plan on rare diseases in November 2021. I was very happy to support that. And at national level here in Ireland, we have the Health Pricing and Supply of Medical Goods Amendment Bill 2021, which is being sponsored by one of our guest speakers, Deputy Padraig O'Sullivan, and well done to Padraig. And he hopes to establish a unique pathway for orphan medicines in Ireland. And I think that will complement the work at European level. So it's a good time, to focus on this issue of rare diseases. And many of you have worked on this topic for a long, long time. But as we know, COVID-19 pandemic has brought about, a greater awareness, certainly at EU level, or opportunity, I suppose, as opposed to awareness of EU health competency as well, and the need to work at European level and complement national level, even though health is not as such a European competency. But we're seeing even in cancer all that much greater cooperation. And I think there's a lot of scope there. Obviously, we want to have a solutions-focused discussion today and really look at the rare diseases landscape in Ireland, if I can put it like that. And let's look at how the revision of the EU orphan and paediatric medicines regulation can improve patient access to rare diseases therapies and determine related policy and engagement priorities for us here in Ireland. I mean, this whole question of the rate of innovation and access to medicines and costs and reimbursement and how national governments can handle this is really a huge issue. I mean, given the rate of innovation and the need for patients to access the best innovations and new medicines, we really have to accelerate the way we do this. It's taking a long time still to get drugs approved in Ireland. And there are, serious issues because Irish patients have less access to new drugs than other European citizens. And people with rare conditions really struggle to get genetic testing. And of a total of 34 European countries, Ireland ranks 24th for access to rare diseases medicines. So that's something we have to improve on. Given all of the developments and success Ireland has had in many ways in our economy, that should not still be the situation. For example, Denmark approves rare diseases medicines 3 times faster than us, and the waiting time for a priority rare disease consultation can be very long. So look, under Irish legislation, there's no differentiation between orphan medicinal drugs and mainstream drugs. And orphan drugs continually struggle to get reimbursement. So let's see what the EU Commission has to say about that. As a member of the European Parliament across party lines and PKU, I'm constantly inspired by patients and their advocates, and we have them here today. So look forward, to having that patient-centered perspective put center stage. So we're looking for solutions here today. There's great experience on the panel, and I think it'll be very interesting. Now, let me get on with introducing our very first speaker. I'm delighted to welcome Florian Schmidt. Florian is the Deputy Head of the unit of the EU Commission's Pharmaceutical Unit in the Directorate General for Health and Food Safety, known as DG SANTE. He is a lawyer by training and joined the European Commission in 2004, has huge experience. Amongst other things, he was involved in the implementation of the new pharmacovigilance legislation and followed the pediatric regulation, as well as general legal matters and court cases for the EU Commission. So Florian, thanks very much for your time this morning, and we're looking to you to set the scene at a European level on this issue. Over to you, Florian.
Thank you very much for these kind introductory words, and thank you for inviting me to participate in this conference. And it's great to see so many participants here. I like really the title of your event, because you refer to a landscape, and we need this landscape really to make a positive influence on rare diseases and to help patients with rare diseases to make a difference. And there are many different policy interventions we can think of, and they are really complementary, be it at national level or at European level. And only these complementarity in the end will make the real difference to patients and help them. But let me speak in my introductory words give some words on what we are currently looking at with regard to the revision of some legislative pieces. You were referring to that we are in the Commission are looking at the legislation on medicines for rare diseases and medicines for children. And these are two pieces of legislation that have been introduced basically 20 years ago to make a difference in this field, to address a market failure at the time that there was no development of, or rarely development of medicines in this area. And it was felt we need a particular push, a legislative push, to support that development. And if we are looking back at the last 20 years, we see that this legislative intervention has made a positive difference. We see more medicines for rare diseases approved. I mean, we are speaking roughly of 200 medicines that came to the market due to the regulation, under the regulation. And we have a system where we are observing the pipeline, and we see a lot of new products being in the pipeline. Still, I mean, there are so many rare diseases, and the current available therapies only cover a fraction of these rare diseases. We are roughly speaking of 95% of rare diseases still not being sufficiently addressed by medical medicines intervention. So there's still a lot to do, and that's one of the reasons why we said in the Commission we have to revisit this situation, have to evaluate what were the success stories of the current legislation, and what can we do to improve the situation to make even a bigger difference in the future. The other thing what we wanted to look at was also mentioned by you, Frances, was the availability and accessibility of the products that are authorized, because indeed we have the situation that we as Commission, based on scientific opinion of the European Medicines Agency, approve or give a marketing authorization for a new orphan medicine, but this does not translate into the immediate availability of that product in all member states, because there are then different situations in each of the member states. There are discussions with the national pricing and reimbursement schemes, and sometimes we even observe that companies also have a staggered rollout plan, that they only start in the bigger member states and then come only slowly to other member states, creating some frustration in the system. And then a third item I want to mention is scientific and technological developments. If we are speaking of a legislation that is 20 years old, then obviously it has not fully taken into account technological, scientific developments that happened in the meantime. And these are some major reasons why we thought now it's a good time to take a step back, to look at the issue and to review the situation. Not with the intention to shake the boat, so to say, but to build on the success stories we already have and to improve where necessary to tackle these objectives. And I mean, the insiders here in the webinar will know that over the past year, we have done outreach activities to present our ideas, to do public consultations, to get input from patients, from academia, from doctors, from the industry, to get their perspective, what is working well, what is working not so well, and where do we need an improvement. And we are currently in a phase where we are digesting this input, doing an impact assessment of possible options that could be used to adapt the system. And then with the ambition that by the end of the year, we will present to the European Parliament and to the Council a legal proposal for the amendments that we think are necessary to have a joint discussion with our co-legislators on the way forward. And generally, I think what we are receiving back from the Parliament and the Council is a great openness to discuss those changes and then to take the appropriate steps to improve the system and make a further difference to the current situation. We will certainly profit in this regard also from some other recent legislative advances, like the recently adopted health technology assessment regulation, which helps member states in assessing the effectiveness of those treatments for reimbursement decision, where also now under the new system, some cancer medicines in the orphan area are included, and that also will hopefully make a positive step or contribution in the future to increase the availability in the member states. These are just a few very limited introductory reflection, but happy then to engage further in the webinar and take further questions. Thank you.
Thanks very much, Florian. And look, that's been a really important scene setting for us. You talked about how the legislation 20 years ago made a difference, but of course, we also have to be very conscious of that very disturbing statistic that 95% of rare diseases are still not addressed by products and by innovation. So quite a journey ahead, but very good news that it's going to the end of this year is going to see it being open for amendments and discussion with, and that the Council are very open to it and the Parliament will be as well. So that's really, important information for all of us, I think. By the way, I just want to mention that we're joined on this webinar by, a lot of people, including the Family Carers of Ireland, the Irish Cancer Society, TRASNA, Rare Diseases Ireland, PKU. So look forward to hearing, what you all have to say when we get to the chat and the questions. Our next speaker, whom I'm delighted to introduce, is Deputy Derick OSullivan. Derick is a Fianna Fáil TD, representing the constituency of Cork North Central. He's been a very vocal advocate on behalf of his constituents and the rare disease community since his election in 2019. The good news is that he currently has a bill before the Oireachtas, the Health Pricing and Supply of Medical Goods Amendment Bill 2021. And this bill seeks to amend existing legislation and put in place a better structure to assess orphan medicinal products appropriately. And if passed, Padraig hopes that this legislation will ensure the timely delivery of critical medicines for patients with rare diseases. So over to you, Padraig, and thank you very much for joining us this morning.
Yeah, thank you, MEP Fitzgerald, for facilitating this important discussion this morning. And good morning to many of my fellow contributors who I've met predominantly over Zoom over the last while, and just like to welcome the online audience as well. I suppose my purpose here this morning is to outline where Ireland is at in terms of rare diseases, and I'll follow on with a brief outline of my legislation that I'm currently attempting to steer through the Dáil, namely the Health Pricing and Supply of Medical Goods Amendment Bill 2021. If I'm brutally honest, Ireland is a mixed bag when it comes to providing for rare diseases, for rare disease patients. In recent times, positive steps have been seen the introduction of a national rare disease plan in 2014, of which many recommendations were implemented, including the adoption of a national cancer plan, and our island excelling as a biopharma hub, especially in the manufacture of essential life-saving biological medicines for many diseases, such as different forms of cancer, rare cancers, HIV, immunological disorders, and rare diseases. Sadly, we are still waiting for the publication of the successor to the 2014 National Rare Disease Plan, despite a commitment in the programme for government to deliver such a plan. So the wait goes on in that respect. Despite the small improvements I've mentioned and our success in the biopharma industry, there are a number of challenges that are delaying progress, particularly on the issue of rare diseases. These include lack of good quality and usable data for patient care and for service planning, low access by patients to new medicines and new treatments, low activity in research and clinical trials. As a nation, we are right to be proud of our innovation in manufacturing. However, we are laggards in a European context for patients' access to new medicines, particularly for rare diseases and rare cancers. Patients in Ireland wait 1.5 times longer than those in England, 3 times longer than our Benelux peers, the Netherlands and Austria, and 4.5 times longer than Denmark, our peers in terms of population and national income, to access new medicines. In response to a parliamentary question submitted by a colleague of mine, Deputy Michael Moynihan, the average waiting time for approval of an orphan medical product in Ireland was 1,361 days. Excluding one extreme outlier, the wait was 1,138 days. Approximately a year to make an application, over a year for an assessment, 429 days in fact, and 289 days negotiation, and a further 217 days between securing a positive decision from the drugs group and that being ratified. Suffice to say, the system is cumbersome and not fit for purpose. In a European context, only 35% of medicines licensed in Europe since 2016 are available here, compared to 65% availability in our Western European peer group. Ireland is second last in Western Europe, ahead of only Iceland, and is now preceded by many Central and Eastern European states, including Hungary, Czech Republic, Bulgaria, Slovenia, and Greece, in terms of licensing medicines for rare diseases. The lack of availability of medicines, especially for oncology, has really worrying implications for the standard of care in Ireland. So, given that Ireland is a laggard in this field, as demonstrated above, I have introduced legislation that was originally drafted by a former colleague of mine, Deputy John Brazel, with the aim of creating a separate pathway for the assessment of orphan and ultra-orphan drugs. The HSE itself acknowledges that there is no separate pathway for assessing orphan drugs, but maintains that there are no barriers for reimbursement of orphan drugs under the current Act. And as demonstrated above by the waiting times referenced, there are an average 1,361 barriers, I would argue, 1,361 agonizing days for patients to be told whether they will get access to a potentially life-changing and often life-saving drug. So for clarity, my bill essentially does 2 things. It proposes to remove the €40,000 quality threshold in consideration for orphan drugs under the higher technical assessment and it also establishes a set criteria for consideration of orphan medicinal products, mitigating against low quantitative data and guaranteeing that the HSE will consider qualitative data, engage in risk-sharing agreements with the state, and obliging us to be cognizant of what our European counterparts are doing in terms of drug provision. And importantly, it must be said, all operating under budgetary constraint and emphasising value for money and the cost effectiveness of meeting health needs. Departmental critics of the bill suggest that the removal of the quality threshold will in some way open the floodgates for orphan drugs to the detriment of the state's finances. But this bill couldn't be any clearer in terms of fiscal and budgetary responsibility. It's a fallacy and a misnomer to suggest otherwise. Other states operate this model I am proposing, and quite effectively, I may say so, and I will hopefully get a chance to highlight this later. So to conclude, there have been significant positive progress under the current government on rare diseases. For instance, 30 million for new medicines in the last budget, in addition to the 50 million the previous year. It's a positive signal that the government backs innovation. The recently signed state industry agreement covering the next 5 years is another positive development. The industry has agreed to very significant additional rebate, which will lead to substantial savings on medicines in the medicines budget over the next 5 years. This must be used to reinvest in new medicines and give more patients access to new treatments. But despite this progress, a lot more needs to be done to ensure the best standard of care is available to patients in Ireland. And I ultimately think that my legislation, which will transform the HTA process, is that first step. Thank you.
Padraig, thank you ever so much, and for being such a strong advocate. Clearly, there's a lot of work to be done in Ireland in terms of access to medicines, and it is disappointing that we're lagging behind so much. And I think we'd all wish you success with your bill, and it will certainly create greater awareness, I think, at every policy level, from the Oireachtas, to the HSE and every place else as well, and offers some hope to accelerate the access. And you've also made some points about some of the, the useful developments in Ireland as well. So thanks, Padraig, and we look forward to hearing more from you in the Q&A. Now I would like to introduce Rachel Finnegan. Rachel is Senior Director of Government Affairs of BioMarin and leads BioMarin's political representation across Europe, the Middle East and Africa. In this role, she oversees the development and implementation of local, national and EU legislative strategies and political advocacy around rare diseases. So she can give us a great overview about what is happening in this area in different places, and indeed how it applies to Ireland. Rachel, you're very welcome. Over to you.
Thank you very much, MEP Fitzgerald. So just maybe first of all, a thank you to yourself and also to the European Parliament's office in Dublin for organising what I think is a very important discussion. I'll just begin with a few words about BioMarin for those of you who aren't familiar with the company. So we focus on developing innovative therapies for rare diseases. We have various therapies currently available for PKU, for achondroplasia, which is a rare form of disproportionate short stature, for CLN2, which is an ultra-rare form of Batten's disease, and for Morquio-A syndrome and Maroteaux-Lamy syndrome. We're also active in the gene therapy space, and we're currently investigating therapies for rare diseases such as severe haemophilia A and PKU, among others. We have quite a strong presence in Ireland with over 500 people between our EMEA headquarters in Dublin and our manufacturing plant in Cork, which is our only plant outside of the US. We've also been through 4 reimbursement processes in Ireland and will embark on another evaluation later this year. So I think Mr. Schmidt and Deputy OSullivan have already very clearly laid out some of the different developments ongoing at the Irish and the EU level. So what I'd like to do is focus on the dynamics between both of these and talk a little bit about the impact that these developments may have for patients' access to rare disease therapies in Ireland and across the EU. And a key point that I'd like to highlight is that the developments happening at the European level will not resolve the underlying issues in the Irish context, which I think Deputy OSullivan has quite clearly laid out. I think Ireland's assessment and approval process for orphan medicine still does need to be reformed, irrespective of any developments occurring in Brussels. So looking perhaps at the Irish level, BioMarin strongly supports the objective of the bill that Deputy O'Sullivan has introduced. So looking to establish specific criteria for the assessment of orphan medicines. And if I think about this from an EU perspective, I think it's key that the methodologies that are used to assess orphan medicines under the new HTA regulation, which Mr. Schmidt has already referenced, I think it's key that these methodologies also consider the unique characteristics of orphan medicines. So as it currently stands, traditional HTAs, health technology assessments, are not appropriate to assess OMPs, given these unique characteristics, including, for example, small patient populations. In terms of the HTA regulation, just to finish on that point, again, I would underline that member states will still remain responsible for conducting their own pricing and reimbursement processes. So despite the regulation coming into force, it will be 2025 for ATMP, so advanced therapy medicinal products and cancer therapies, and then in 2028 for orphan medicines. However, I think irrespective of this European HTA legislation, the processes in Ireland will not be resolved. As I said, the pricing and reimbursement negotiations will still take place at the national level. If I move on then to focus on the revision of the orphan medicinal products regulation, I very much agree with the point that Mr. Schmidt made about the fact that there has been an increase from, I think it was 8 in 2000 when the legislation was first increased. So from 8 to over 200 therapies, orphan medicinal products that have been approved in the EU since the introduction of the regulation. So I think this really underlines the fact that the regulation has been a success. And from the report that the Commission published about the impact of the legislation to date, we've seen that 6.3 million people living with rare diseases and their families in the EU have benefited from this legislation. And it is true, as we've heard, that there are still many rare diseases that lack a treatment option. But I think this underlines the point that it's crucial that we continue to incentivize research and development for orphan medicines in Europe, given the complexity and the risk involved in developing these therapies. In terms of the changes that we understand are being considered to the orphan medicinal products regulation, I think a key point is that we very much hope that any changes will build on the success of the legislation to date. And similar to the HTA regulation, the OMP regulation itself will not resolve the issues that Irish patients are experiencing at the moment in terms of access to innovative medicines. The regulation focuses on issues like the designation of orphan medicinal products and also the incentives provided to encourage research and development. It doesn't focus on the reimbursement of OMPs, which remains a national competence, so to be dealt with at the local level in Ireland. So again, just to make the point that these issues in the Irish system do need to be explicitly addressed in their own right. I won't go into more detail in terms of the challenges, but perhaps in terms of solutions. So at the Irish level, I think the bill that Deputy O'Sullivan has proposed is really a great starting point to try and optimise the assessment and approval process for orphan medicines in Ireland. We're also aware that there was a review conducted of the reimbursement process in Ireland, the Mazars report, and that has been delivered to the Department of Health in early 2020. And I think having that report published and looking at the possible solutions that it may provide would also be a good step in terms of trying to improve the reimbursement process in Ireland. Deputy O'Sullivan also just mentioned the rebates that the industry is providing, and I certainly agree with his view that sort of trying to ring-fence these rebates for orphan medicines to ensure that they're reinvested in the financing of other orphan medicines would be a good idea. And then in addition, to try and increase the political focus on rare diseases in Ireland, we would also believe that the establishment of a cross-party parliamentary group in Ireland, similar to what we see in other countries and also at the European level, would be very helpful. And then just solutions when it comes to the revision of the orphan regulation at the European level. I think the key point here is really trying to make sure that any changes, as I said, build on success to date and maintain an attractive rare disease ecosystem to ensure that companies like ourselves can continue to undertake research and launch therapies for people with rare diseases in Europe. So I think I'll leave it there for now, and I look forward to hearing the rest of the contributions and to engaging in the discussion that follows. Thank you.
Thanks very much, Rachel, and interesting discussion there, a presentation about, what is the interaction between what happens at European level and Irish level, and in fact, how we need to be getting on with things in Ireland almost separately. I'm going to ask Florian, not now, but later on in the discussion, to comment on those points you made about, developments at European level, whether they impact here, how they impact here, but also you've obviously very clearly stated that we need action here in Ireland, and we need to make greater political discussion. I think your idea of a cross-party group, of course, it always helps as well when you're dealing with issues like this, but definitely there's a need for greater general awareness, I would say, the point you make, and political awareness about the need to accelerate action on all of these issues. So thanks again, Rachel. Now I'd like to introduce Bernadette Gilroy. Bernadette, you're very welcome. Bernadette is chairperson of the PKU Association of Ireland. She's a lecturer at MTU and also a researcher at DCU. She lives with phenylketonuria, a rare metabolic condition that obviously affects a person's ability to metabolize protein, and if left untreated can lead to other issues. Bernadette, you're a strong patient advocate as well as a researcher, and I'm delighted that you're joining us this morning. I know the work that you've been doing, and really look forward to hearing you again this morning. Thanks, Bernadette.
Thank you very much, Frances, and thank you so much for hosting this event. Such an important discussion is happening here today. So these opportunities, first of all, I need to say are rare. And as such, I've reached out to rare disease advocates to ensure that I'm representative of a collective voice. I want to start by saying that rare diseases are not rare. They are collectively common. And we need to demystify rare diseases, and the symptoms of which in many cases are not rare. 400,000 people on the island of Ireland have a rare disease. 30 million adults and children across Europe. That's 6 to 8% of our population, and their families who are also affected. Rare conditions require an accurate diagnosis and early intervention and immediate access to innovative treatment. There is a real need for urgency. Time is of the essence. Living with a rare disease can make one feel isolated, helpless, disempowered, and extremely vulnerable. This is due to the lack of information, lack of appropriate specialists, and a lack of general understanding in society. Patients and families are discriminated against and excluded in many societal settings, such as healthcare, the workplace, and in education. Innovative medicine not only transforms a person's quality of life, but that too of their families. In the case of PKU, the research highlights that 70% of adolescents and 60% of adults who have PKU do not strictly adhere to dietary therapy, the most prevalent treatment for PKU to support their brain health. Dietary therapy is not fully supported in our current systems. All treatments do not suit all patients with the same conditions. Treatments for rare diseases can save lives. Treatments give time to patients and their families by reducing the burden of care. They give a person the opportunity to reach their full potential and to further engage with and contribute to society. Most importantly, they provide hope, and hope transforms people. With it, it brings strength, it brings resilience, and it restores faith in systems. Policymakers can really help by being educated, by simply listening to the voice of patients and their families. They are the real experts. We need to listen. It makes rare disease communities feel empowered, many of whom feel isolated, deflated, and disempowered. Include the patient and family members at all level discussions and at all times. I've attended events where patients and family members have been invited to speak about their experience and have been added to the bottom of an agenda, and attendees, including policymakers, do not wait to hear them speak. Policy must support rare disease patient advocates in their work. Many patient advocates in rare disease communities are triple jobbing, caring for themselves or a loved one, in full or part-time employment, and advocating. None of us planned to be here. To be effective, we need advocacy networks to be supported. Many advocates would like to be afforded the opportunity to reduce their work hours, but cannot afford this opportunity. Again, nobody planned for this. So many drop out of the system with skills and their extensive experience in advocacy after just a few years. They are burnt out, deflated, and reflect on all the sacrifices that they have made and ask the question, was it worth it? The cycle begins again and again and again. Then there are many who wish to advocate for themselves or their loved one, but simply do not have the capacity to do so. Afford them these opportunities by supporting research, lived experience, patient-centered outcomes, true public and patient involvement research with patient and family research partners. The Raindrop project at UCD PPI Ignite is a great example of this. Our state in Ireland has for the first time invested in a project solely based on rare disease research, with an investment announced earlier this year in a rare disease clinical trials network. This is hugely welcomed and we look forward to seeing this progress. We need to expand our newborn screening programs and to support genomics and genetic services to support an earlier and more accurate diagnosis. Our policies need to acknowledge that many conditions are lifelong and some are diagnosed in adulthood. The transitioning phase to pediatric to adult services is one of the most vulnerable times in a person's life. Support medical professionals so that they can share their expertise. We need to integrate rare disease and education curriculums for many professions such as health and education, and create opportunities for medical professionals to work together in education and research nationally, and continue to support ERNs that support this mechanism. Why is it that so many educational institutions remain in the dark when it comes to rare diseases? Parents say they are considered anxious when they express their concerns because educators are not getting the information elsewhere. In the case of metabolic conditions, the food industry remains uninformed. Protein labelling needs to be addressed, and the information on rare diseases and food intolerances should be shared by our national food safety authorities. Our patients and families need to be consulted when this does eventually happen. At a minimum, we need to be integrating European guidelines where available on specific rare diseases. There are minimum standards of care for different rare diseases, PKU for instance, and this has not been practiced on the ground. Blood level results to manage brain health in our adult unit in Ireland for metabolic patients takes 2 to 3 weeks to be communicated to adult patients. And Statement 16 in the European Guideline recommendations states that it should be less than 5 days. These are the minimum standards of care due to the limited quantitative research on a small population size. Existing rare disease policy must be implemented. There will be many cost savings. Rare disease plans should include timelines, accountability, and transparency. We need to be proactive and not reactive. We need consistent investment in infrastructure to support existing rare disease plans in Ireland and across Europe. Thank you.
Thanks very much, Bernadette, for that overview. And I think one of the really important points you've made is about the isolation that people can feel. And I love that phrase you used. Rare diseases are not so rare, they're collectively common. And I think that should be a kind of a motto for us, because I think sometimes it's seen as kind of a very marginal issue, where it isn't at all. It's very central to many, families and high enough numbers across the island of Ireland. So thanks very much for Bernadette. You're a great patient advocate, and great to hear the work that you're doing. So on to our final speaker now, and that's Derick Mitchell, who is the CEO of the Irish Platform for Patient Organisations, Science and Industry. Derick has a huge background in research, in strategy and advocacy from over 12 years experience, spanning a number of leadership roles in research and working with many different stakeholders in Ireland and at EU level. So I'm very keen to hear what his perspective is. Derick, you're very welcome this morning. Thank you for joining us. Over to you.
Thank you, Frances, and thank you for the invitation to speak today. And it's wonderful to be coming in after Bernadette's wonderful perspective coming from a view of people who are living with rare diseases in Ireland. IPPOSI was set up by patient groups in Ireland, and whereas we're not exclusively focused on rare diseases, given our foundation by many rare disease groups, we continue to work to insert a rare disease dimension into the wider health policy and health innovation space in Ireland. And I think that that's something that is coming through from a lot of the other speakers in terms of the need for specific investment in rare disease policy and implementation of such, but also in terms of the mainstreaming of rare diseases as an area that can act as an exemplar to others. And hopefully I'll be able to give some examples of where rare diseases have been truly innovative. But one thing that's really, really common to all of rare disease policy and initiatives is that because patients and their families and carers are ultimately the true expert, that the principles and methodologies of co-design, co-production, and patient-led innovation is truly embedded within rare diseases. So that has to continue, and Bernadette's points on this regard are so on the button there. But it is interesting, even at a time of great turmoil, maybe in the north of this country, that Northern Ireland was able to release an action plan for rare diseases, a 14-point plan over 12 months, just earlier this month. And if that can happen in the north of this country, then why can't it happen in the Republic? So action plans at the European level and indeed at the cross-border level are hugely important to bring that sense of urgency, that sense of that time is not escaping people with rare diseases, because we can clearly see that we are behind other countries in terms of accessibility and availability of certain innovations, and we need greater investment to try and bring us back up to where we should be. So rare disease policy in Ireland needs leadership, and it needs the focus to make that policy a reality for people living with rare diseases. I would certainly encourage everybody here to read the latest edition of the Easy Guide for Rare Diseases, which was published, the second edition was published by the Rare Disease Task Force, which is a way in which groups like IPPOSI and Rare Diseases Ireland, Health Research Charities Ireland, Cystic Fibrosis Ireland can come together to produce outputs that really reflect the true nature of living with a rare disease in Ireland. And that Easy Guide was one of the main reasons why rare diseases was called out as a specific area in the current programme for government. So just to kind of focus on two areas that IPPOSI focuses on as part of our role in that task force, which has now evolved into what's called the Rare Diseases Forum. And that's the two areas I wish to focus on is the health information space and also the genetic and genomic space. So in terms of the health information space, I think it's wonderful that Florian is here to talk about maybe the parallel policy initiatives that are happening at the European level. And the one area that we're really interested in is the European health data space. And that's a very ambitious European Commission proposal for where there can be ultimately more fluid exchange of patients' health data, as well as information between healthcare professionals. And that would promote a better care pathway with no interruption between the life stages, either childhood or adulthood, or where you might live in Europe. So that ambition needs to be matched at the national level. And I fear for Ireland's involvement and ability to align with that ambition because of the lack of investment and leadership in the digital health space in Ireland. The fact is that for the rare disease community, we still don't have ORFA codes inserted into our clinical information systems. So we don't know just how many rare disease patients there are in Ireland. Equally, we can't, one of the reasons why I think we're so slow in Ireland for the reimbursement of orphan medicines is because we lack the digital infrastructure to be able to measure the effectiveness of these new treatments in the real world. So, and that's one of the reasons why I think the state is really hesitant about reimbursing these, because it only gets one opportunity to negotiate the price, and that once that approval is given, it has no ability to then reassess just how effective these new treatments are. And I would also emphasize the point that there has been huge successes as a result of the European orphan drug regulation, not least in Ireland, where areas such as in cystic fibrosis, we're now seeing the true impact of the new, more personalized treatments, but also the way in which, through pipeline mechanisms, we can actually do this in Ireland in terms of managed and staged access to new and innovative therapies. And I certainly would welcome the calls for greater investment with the advent of the European reference networks and their role in terms of data collection. We don't have care pathways or associated with the European reference networks in Ireland, and we need more resources to make that happen. And then finally, just in terms of the more personalized nature of these new treatments and therapies, the lack of investment in genetic and genomic services in Ireland is actually contributing to an awful lot of the costs associated with our healthcare. We know from a survey of rare diseases people in Ireland from Rare Diseases Ireland that 37% of people living with rare conditions are waiting over 5 years for a diagnosis, and that's having a knock-on effect on the waiting lists. So there's a need to secure budget and investment in genetic and genomic services in Ireland, and we've noted that very recently a national director role in this area was refused by an individual, primarily due to the lack of finances and the lack of ultimately the commitment around this role. So this really needs to be addressed. And IPPOSI is doing our bit to help in this, in that we're organizing a citizens jury on genomics as an area to improve that level of awareness of the importance of investment in this area and the knock-on effect that this investment can have for rare diseases. So I'll leave it there and happy to contribute to the later questions and answers.
Well, thanks very much, Derick, and for the amazing work that you're doing. I mean, it's really inspiring to listen to you, as it is to all of our presenters today. And I thought it was important that you talked about the complementarity of, EU initiatives in Ireland as well. While, as Rachel said, there are some specific issues too, there is scope for complementarity too. And let's make sure we get that action plan for rare diseases within the next year. It's in the programme for government, slightly different word, but it seems to me it's absolutely essential. And perhaps out of today's seminar, a few of us could work together to make sure that this happens quickly. I've interesting questions coming in, including one from a colleague from the Oireachtas, Dennis Naughton, who's joined us. Welcome, Dennis, and other councillors who have joined online as well. We need the political action as well on this, as Padraig has shown. So thanks, Derick. I'm now going to invite all of our speakers to become part of a panel discussion so that all those registered can see everybody. So there's Florian and others joining us again. So look, if there's any particular points that have come out in the discussion so far that anybody would like to comment on, please do, but I will go to the structured questions in about 10 or 15 minutes. But look, let me begin. Maybe, Padraig, I'll start with you. Maybe just ask you to get the ball rolling. What inspired you to take up this cause? I mean, it's great to see politicians getting actively involved.
Yeah, thanks, Frances. Yeah, I suppose 2 years ago when I was first elected, I met a number of constituents of mine who suffer from a rare disease called amyloidosis. And I suppose I've described it in the Dáil previously as probably the hardest conversation I've had to have with somebody sitting around their kitchen table telling me that other family members of theirs who had the disease had since passed away, and now that they had been diagnosed with it, and that they were being denied access to this potentially life-changing drug, patisiran. Now, the good news for those families which were affected in Cork, and it actually was quite prevalent in Donegal as well, that drug was since approved. So it potentially has life-changing impacts for them. So I suppose that's how I got involved at day one. And since then, I've been liaising with different patients groups, different pharma companies, and many Oireachtas colleagues here who have similar experiences with advocating for different people suffering from rare diseases. So I suppose that's what got the ball rolling. And when my former colleague, John Brazel, who unfortunately didn't get re-elected, I suppose when I saw the work that he had done in the field, it just seemed natural that, you know, somebody else would pick up the baton in that regard and carry on his good work. So that's what's brought me to the bill that's presented today.
Yeah, I mean, private members' bills always need a lot of support to get through, to make it actually through the Oireachtas in a timely way. So I think the cross-party support is probably important as well, and obviously government support. But I guess when you were doing the work, you came across quite a bit of good practice in other member states, and we've heard that from a number of our contributors, that there is better practice and you know, models we can take from other countries to really improve things here. Florian, I'll ask you to comment on that first, and then I'll go to others.
Yeah, I suppose there are lots of countries, and look, as the majority of speakers have attested, we are laggards in this regard. But like Sweden would be, I suppose, a similar example to ourselves, where everybody has the right to healthcare from the outset, and patients are prioritised on the basis of their need. And they operate an assessment process where there is no quality threshold. So officials in the Department of Health would tell me that if we abandon the quality threshold of €45,000 that has saved the state so much money over the years, if we abandon that, it's going to place an awful lot of pressure on us from a budgetary point of view. But in Sweden, they operate without that quality threshold, or they have one set to a higher standard. So like Sweden can do it, I think that we can. Scotland, I suppose, is a country that would be of similar size to us. And by 2020, of all drugs approved by the European Medicines Agency, 61% of them were available in Scotland at that time, and less than 10% were available in Ireland. So again, if the Scots can do it, you know, for a country that's relatively similar in terms of population, and their waiting time for approval for those drugs was half of what it was in Ireland. So again, it just comes down to the political will, I think, to change the process and to provide a separate pathway.
Thanks, Pádraig. Derick, can I bring you in here? Can I just ask you, what's your own analysis of why we are such laggards in this area? I mean, we're a small country. We know people with rare diseases. Obviously, we generally can be very good at reacting to specific issues. You know, is this all about the processes in place for reimbursement of drugs? Is it about, you know, and I'll ask you about, Florian, I'll ask you later, and it's a question that's come in as well about, you know, maybe a European approach to reimbursement. Derick, can you just give us a sense of this? And maybe Rachel will come in here as well. Like, what's your analysis of exactly what's going on, Derick?
Well, ultimately, I think it comes back to Bernadette's point about a lack of faith in the system, and that faith from patients on whether the state is acting in their best interests or not is not reflected in the time that's being taken to consider these. And we know that Ireland is taking longer, but there appears to be Ireland's national approach to looking at these new innovations primarily from a pricing lens, and that the one opportunity to reduce the price is in the beginning. And in the beginning, the longer you wait, the lower the price, it seems, in terms of the initial price. But from a patient perspective, we don't even see what that final price is. So it's very hard to have faith. So you can see where the frustration kind of builds. But also there's a lack of transparency and communication about the process. And IPPOSI has been working closely with the likes of the NCPE and HICWA to try and really embed patient and public involvement in the process, so that there would be greater opportunity to influence that. But again, there's a lack of communication about where the impact of that is actually happening. So patients are investing their time in a process that they believe that they should be getting involved in, but there's no real kind of communication back about just what impact they're actually having. So I think...
Yeah, Derick, sorry to interrupt you there, but is that really about the negotiating process between the pharmaceutical companies and the government, the HSE, wherever, the Department of Health? Is that what you're talking about, really? That it's too centered on that, or am I misinterpreting what you're saying? I mean, you're saying there's a lack of transparency. I mean, there always is, obviously, when you're, you know, in those kind of budgetary discussions, or not even budgetary, you know, tendering, I suppose. But just explain a little bit more what you think is where the lack of transparency is.
Well, there's two aspects to the process. There's the assessment, whereby you look at the evidence coming through from the clinical trials and you make a recommendation. But then there's the reimbursement process where that negotiation happens. And we've looked at it from a patient perspective in terms of where patient input and involvement would actually improve that process. And we released a charter in 2019 on this. But on the reimbursement side, the state has its de facto kind of policy, which is around the EFA agreement, which has been mentioned already. But what's clear to us is that whereas the companies wish for greater use of data and real world data to be incorporated into these reimbursement decision makings, the state doesn't have the facility or indeed the infrastructure, the capability to put these systems in place. So there's a real dichotomy there, that you've got a negotiation position from the state, which is basically we can't measure these in the real world, or at least we don't have the resources to measure this in the real world. Whereas the companies we find are increasingly very willing to engage in these processes. But again, it's hard for patient groups and for patient organizations to really appreciate when these negotiations are actually happening, and maybe what is the ultimate cause of the delays that are being happening.
Okay. All right. Let's a quick word from Rachel, and then I'll go to Bernadette and then Florian on slightly different topics. But on this, Rachel, anything you'd like to say about the points Derick has been making about how we could, this is all about accelerating, I guess, both the recognition of innovative drugs, but also the reimbursement and, patients getting a quicker service really at the end of the day.
Yeah, so perhaps I could pick up on a few of the points that Deputy OSullivan and also Derick have just made. So I think, first of all, there are obviously, as Deputy OSullivan has outlined, other models from across Europe that Ireland could look to. And I think in all of this, the key points are making sure that there is sort of certainty. I think the current situation is a lack of certainty, and also ensuring that the process is time bound. I think one of the issues that we see in the Irish process is that in certain stages of the assessment process, there is no defined time periods, which again leads to that lack of certainty. And I think also transparency in terms of, also from our perspective, we'd like to see more transparency in terms of that process and putting in place a more predictable and, as I said, time-bound process. I think a key point is also the assessment criteria. And again, this comes back to this point we've been touching on around having appropriate mechanisms in place to assess orphan medicines. As it currently stands, rare disease therapies in Ireland go through the same process as other therapies, meaning that given the small patient populations, they're deemed to fail the cost effectiveness assessment. So I think putting in place a process that could address some of these points would really be sort of a way to address some of these issues.
Rachel, that's very interesting. I mean, that is something that should be entirely doable, I think, to have it more time bound. And as you say, in projects build this, that separate access route as well, because it is rare diseases. I mean, it may well need absolutely something different. And maybe the action plan on rare diseases, both at the European level and an Irish level, could address that. Bernadette.
I'd just like to first of all acknowledge that the current process being not fit for purpose, I'm delighted to see that this is happening. It's hugely welcomed, and it's certainly an improvement to see a separate assessment process for HTA, for orphan medicines. I would say that the rare disease community certainly needs support in getting that qualitative research available to inform that process. Just in terms of solutions as well. 15% of the HSE budget is spent on medicines, and I think we really need to scrutinise other aspects of the HSE system, budgeting system, in the same way we do for medicines, to make funds available. And then we need to discuss generic medicines as well, as a cost-saving measure, as well as, speaking to patients who are currently taking expensive medicines that may not be working or may not be as effective as they would like, because the same medicine for two people with the same condition, it might not work for one, it might work for another. So we need to reassess and ask the patients how well these medicines are actually working, so that money can be redirected, those funds can be redirected elsewhere. So by improving our internal systems as well will certainly help to support this. Thank you.
Certainly, I would say from my own experience, the interaction between, patient advocates, policymakers, the scientists and the medical community is really, that's a great model going forward, that everybody is engaged and has the opportunity to be engaged. We've lots of questions coming in, so I want to get to those. But before I do, I'll ask Florian to come in on what you've been hearing so far. I mean, at one level, can Europe influence, Irish national policy? We've heard kind of slightly varying kind of comments on that, Florian. And I will come to you with a question about, actually, I might bring it in now, a question. It's the one from Dennis, actually, that in light of the fact that the EU negotiated and purchased COVID vaccines, should we not now be looking for a common EU-wide pricing and reimbursement model? Now, I don't want to go, too far away from this discussion, but there's obviously an increased move, and I see it in the Parliament, to have, more common tendering for all sorts of things, and why not for drugs and so on. Now, it's complex, obviously, and innovation has to be respected, and companies and so on. But Florian, maybe your reflections on the conversation so far from your perspective.
I think it shows again the complementarity in the policy discussion and in the policy solutions. And I clearly agree with the rest of the speakers that at European level we can do certain things, we can enable certain things, but we cannot always provide the ultimate solution. And the pricing and reimbursement decisions at national level is one of these examples where then member states have also to take their role, their own decision about their national system, and also to adapt it. Still, what we can do at European level also to facilitate discussions at national level. I mean, we have heard about different models other member states provide, best practices exchange, and these are often in the European model inspiring for member states also for these pricing and reimbursement decision. And we have also seen that several member states came together to jointly discuss also pricing and reimbursement approaches. So while this is a national competence, where we can help is in sharing these best practices, but also what we have introduced, for example, is this matter of horizon scanning, so that the national health system are early noticed about what is in the pipeline, also then to use this information to have an early discussion, where do I put my funds and so on. Finally, to your question about joint purchase of orphan products. I don't think, I mean, it's the vaccines were a particular story, certainly from our perspective, a success in the sense that we could provide the product at the same time in all the member states. But I don't think this is easily copied to all the medicines, where maybe there are opportunities, and where as Commission we are also open to consider opportunities for some medicines to discuss, is there an opportunity for joint procurement on some of these medicines. But again, I don't think this will be the magic solution that might be for one or two products pertinent, but not for everything. Thank you.
At one level, you immediately think that this is possible, and then when you go into it, it could be very complex. Now, I know you, the speakers can see the questions coming in. There's a question there. It's the first one that came in, and it's from Tobias Hagdown in Germany, German PKU Association. And he's sort of saying that, we need to look at unmet medical needs as well. Even diseases where treatments are available, like PKU, should not be excluded from scientific progress. Would you agree the definition should be focusing on inadequate met needs rather than unmet needs? And I'm sure you can all see the point he's making there. Let's see some other questions. Sorry, I have to lean over to see them here. let's go on now. We see what else there are. Yeah, partnerships in Europe will be essential for future funding models. And member states' access to clinical trials, innovation and evidence generation in collaboration with patients will be necessary. So for the reimbursement as well. So you're seeing those questions there. Who'd like to come in on any of those questions? Kind of just slightly technical, I suppose. Rachel, you're going to come in, and Derick. Rachel.
I think Derick, do you want to go first? I don't want to skip the queue. Okay. Thank you very much. So I just wanted to pick up on the point that Mr. Schmidt made about the joint procurement. And I would certainly agree in the case of the pandemic. I think, as he said, you know, the vaccine was sort of almost a public good, and we found ourselves in an unprecedented situation. I think before we could come to a situation where there could be joint procurement of rare disease therapies, there would need to be agreement that would be binding across all EU member states on the value of the medicine, because this, of course, is the basis on which the price would then be negotiated. And while that may be feasible in the case of a vaccine, I think when it comes to a rare disease, where different countries, because of genetic sort of mutations, maybe have a different prevalence of rare diseases and maybe don't have a population living with a particular rare disease, I think this is where the challenge would arise in terms of, first of all, agreeing on the value before there could be any consideration given to joint procurement.
Derick?
Yeah, just in terms of maybe potential solutions to this, and just in following up with Dennis Nocton's question. So there is an idea that's gaining traction across a number of European areas, and that's this idea of that you could have a common EU fund, and that would cover some of the costs of both orphan, but also these advanced medicinal products. But as well as collecting as well as some of the costs of collecting the real world evidence. So that it's something that Eurordis, the Rare Diseases Europe patient group, has been promoting, and I know a number of other groups have supported it as well. But also associated with a fund like that, you'd have to have some mechanism for collecting the data. And certainly we would be huge advocates of strengthening the role of European reference networks in this regard. And I know there's some comments there from Eileen Tracy in the questions and answers that really emphasize the key role that ERNs will play in terms of merging those kind of EU policy initiatives and making them a reality in Ireland.
I mean, that certainly seems, you know, important way forward as well. Florian and then Bernadette.
Yeah, I wanted to comment on two issues. First, on the importance of data and real world data. I totally agree with what has been said, and it was also nice by Derick to mention the European health data proposal, because in a way we know that we have a huge treasure trove of data available at a national level, and in a way with this proposal we also want to make it more accessible and more searchable, and to use it for different purposes, and that's certainly something where we in Europe still have to make positive steps to really use this. The second thing, unmet medical need. I totally agree. This is a key consideration in the rare disease area. You could say every rare disease medicine is addressing an unmet medical need. But what we are considering is, do we need to have this additional reflection? Because in a way, there are already some therapeutic areas which start to be served. So do we have to push industry also into the 95% of diseases that are not yet addressed to provide their specific pushes that we are also getting something there? But this does not exclude that the existing areas where we already have treatments will be totally excluded. If we see there a new breakthrough therapeutic coming on, then certainly that should be supported, but not maybe the incremental small innovation in a field where you already see therapies. Therefore, this discussion about unmet medical need in this area. Thank you.
Important that seems really important that that's clearly understood, because if there are ongoing innovations where there have been some already, of course you would not want to stop those, but I do understand there was some concern about that. And just one point, Florian, that's come in that I want to ask you about. Again, it was a worry from patient advocate groups, and that is that the OMP regulation revision would be narrowing the scope so that a much narrower definition of rare diseases would be used, resulting in many rare diseases being left to the rocky seas, if you like, of the open market. Is that true? Or maybe just a quick comment from you on that, because I think that's a very natural anxiety.
Yeah, in a way, it is not true, because our thinking about why we are looking at this issue is a different one, that we see that common diseases could potentially be orphanized because they are artificially split in subsets depending on biomarkers or so. And we don't think the orphan disease area should be crowded with non-orphan diseases just because they address a small patient population. So that is the primary driver for us to look at this issue, to avoid that we suddenly get more orphan diseases than we are currently recognizing. Thank you.
Bernadette, you wanted to come in, and then Padraig. Bernadette.
Thank you very much. And just to add to that point, yeah, so in relation to, making those revisions, the Commission's suggestion to group similar rare diseases together when assessing prevalence. So in the case of PKU, it could be grouped with, say, hyperphae, HPA, for instance, and this could lead to some combinations of rare diseases passing the current prevalence threshold and therefore no longer individually being considered as a rare disease. So therapies, consequently, therapies for these rare diseases would not be able to benefit from the incentives and rewards. So that is a huge concern for our community. They risk not being viewed as being economically interesting for companies given the small patient populations. And this could lead to patients suffering from these rare diseases not benefiting from future innovation. So it is a big concern, and the ESPKU are addressing that. I see my colleague Tobias has commented as well on the unmet medical need. Tobias from the ESPKU, who are doing incredible work in this area. So the Commission as well is considering limiting the incentives provided by the OMP regulation to therapies that address unmet medical needs. So in this context, the Commission is proposing a legally binding definition of the concept of unmet medical need. And this concept is highly complex, and many factors play a role in determining unmet needs, such as the severity of the disease, the burden of the illness, the ease of the treatment, and the quality of life of people living with PKU and their families and other rare diseases. So it's impossible to agree on a definition that, factors all of these things into account. And for example, what would qualify as a treatment? In the case of PKU, dietary treatment, it does exist, and it is quite effective. And it is difficult to adhere to, and creates a burden for patients and their families. So would this mean that, the medical need for those living with PKU is sufficiently met, and that PKU-related pharmaceutical treatments then would be excluded from incentives and rewards provided by the OMP regulation? So it's important to note, as is in the case for PKU, that treatments for certain subpopulations of people living with certain rare conditions may exist and may be mistakenly viewed as meeting the needs of the entire population affected by that particular disease. So this has also been stated by Eurordis and other rare disease organisations. It would cause problems and potentially leading to lengthy discussions to the detriment of the populations intended to be served. So we do fear the consequences of this.
Okay, well, Florian, I'm not going to go to you on that, but I'm sure you've heard what Bernadette has very eloquently said there, and there's obviously very important points in that. Maybe if you want to comment at a later point on it, but let me bring Padraig in now. Padraig, this action plan for rare diseases, combined with your legislation, combined with the changes at European level that Florian's been outlining, I do think there's a potential mix there that could really help move forward this at a political level. Interested in your views because you've been immersed in this.
Yeah, well, I might be immersed in it, but I'm far from an expert. Many of the people on the call would know a fair lot more than I do. But look, from engaging with people over the last few years, there's a couple of things which I think can be done and that actually don't require legislation. And whether that's the publication of the Mazars report initially here domestically, I think that would give us a good insight into what the department thinks needs to be done on the HTA side of things and to streamline that process. And obviously, again, we revert to what we said earlier in regards to the rare disease plan, and a successor to that plan needs to be published as soon as possible. And it is a commitment in the programme for government. And we're 2 years into that term of government now, so we need to get moving on that. I just pick up on 1 or 2 points, and it's in relation to, I think it was Florian and 1 or 2 other speakers mentioned the issue about data and clinical trials. Like the fundamental point for me that I find most difficult is that it's established fact that Ireland is so far behind our EU counterparts, yet we insist here on doing our own trials and collecting our own data. And I just can't get my head around the fact that because we're so far behind our European counterparts, is there not a basis that we could use the data that they have already accumulated? In some cases, that data will be there for many years, and use that in our own assessment to help speed up our process domestically. And there's just one other point that I'd like to address. It's made by Avril Keenan there on the question board, where she said, you know, that there needs to be increased patient representation. And it goes back to, I think, what Derick said earlier about transparency. And patients do feel locked out of the process and totally blind. And I think that, you know, any approach going into the future needs to be patient-centered. And I do believe that, you know, getting, I suppose, increased transparency around the work of the Rare Diseases Technology Review Committee and groups like that, and I suppose to get that committee to meet more frequently to ensure that we get a steadier flow of drugs approved into the future would be imperative.
That's very helpful. I mean, there's certainly an action plan of which, as you say, the experts on this call, you know, when you put it all together, there's quite a few pieces that you would imagine could happen, could be accelerated. I mean, this comment here, just taking up on your point about learning from Europe, which I always think is so important. Martin O'Rourke, who of course runs TRASNA, which is the organization to help patients access treatments abroad, he says, thank you all for a great discussion. It's important for a small country like Ireland to lean on the scale of Europe for rare diseases and remove barriers for patients accessing treatment in other EU states that isn't available in Ireland. But of course, it's a very basic question you've raised there, Padraig, about, you know, if there's so much progress in other countries, can we kind of leapfrog a little bit? And, you know, why are we caught in this sort of time lag when actually other countries are accessing other medicines for rare diseases and patients are getting access to them quickly and being reimbursed more quickly? And I mean, that's a complex question, but I mean, I might go to Rachel and then to Derick for some comments on that, because that's the nub of the issue really, is how do we accelerate progress on these issues in Ireland? I mean, it's a political question, it's a technical question, and obviously it's political will as well, but you kind of wonder, it feels like the process is very, it's quite difficult to, well, I keep using the word accelerate, but it seems like it's full of barriers is the word I'm looking for. Rachel.
Yes, thank you. I did just want to, if I may, pick up on some of the points that I think Bernadette had addressed around unmet need. So again, from our perspective, also concerned to see some of the considerations mentioned at the European level around potential changes to the prevalence criteria for a rare disease, and also considerations around the introduction of this legally binding definition. So just to say that we share those concerns and, you know, have given some thought to potentially the unintended consequences of some of those changes. And perhaps we can come back to it, because I do understand that the areas of rare disease where there are no therapies is one of sort of the points that's behind some of these considerations. And I think perhaps there are other solutions that could be looked at that would address that point without having those unintended consequences. On the question around data, certainly agree that there are sort of multiple challenges here. I think there's challenges around the actual data itself, but I think then there's also the challenge around resources, which is linked to that. So in terms of data, I think we need to ensure that we have the infrastructure in place in Ireland that we can actually gather that data. And I think that's something perhaps we could look to other countries across Europe to learn from how they've dealt with this. And then some other points that I think we would need to consider is, would patients then have the possibility to decline the collection of their data? You know, we come into the territory then of questions around data privacy. So that is something that would need to be addressed as well in those considerations, and also whether the collection of the data in the long term is actually sustainable. And I think even when this data is collected, there would need to be an agreement, and that probably has to be at the Irish level, around how we would actually use that data and align on what is needed, particularly when it comes to rare disease, where again, we come back to the unique characteristics when it comes to the small populations and the approach to clinical trials. And as I said, there's the resourcing challenge then. So I think we would need to put in place a system in Ireland that would be as simple and least burdensome as possible, so that it wouldn't be taking too much sort of human resource time. So simple schemes that have a balance between the complexity and also the feasibility in terms of the collection of data and the human resources needed. So I think getting that balance right will really be crucial.
That's very helpful, Rachel. Just a question here before I go to Derick from Vittoria Carraro. On the matter of horizon scanning, Florian mentioned, does that mean we envisage the possibility for member states to signal the need and willingness to purchase certain medications? How do we ensure through the legislative revision that the system is more predictable on both sides? So that's a question, Florian, that you might have a look at as well, or Derick. Derick, over to you.
Sure, I can probably just on a couple of points first before on the horizon scanning. So two main points that I want to make. First is around the data space. So one of the things that we could really work on this year is that there is a health information bill that is being drafted. We believe a memo to government was gone to recently about it, and that a heads of bill will likely be coming through later on in the year. It will be really important to, as I said, put a rare disease lens on that bill, so that we can actually collect the kind of data that is relevant to rare disease communities. So that's another piece of legislation. I personally wish to thank both yourself, Frances, and PAUDI especially for using legislation to actually get conversations going about this, and that's a key driver. But as PAUDI has said, there are non-legislative elements that can easily be worked on in the meantime. And one of those areas that I think, coming back to Avril Kennan's point about patient groups don't have a contact point in the Department of Health currently for rare diseases. It previously was under the Chief Medical Officer's remit. Now, the Chief Medical Officer's group has obviously been busy in the last while, but we feel that probably needs to come out of that office and into more European level focused, more research focused areas of the department. And if that can happen, then I think we can have more of these conversations with the policymakers to really look at what are the known knowns that need to be addressed, but also the known unknowns that some people have talked about in terms of proposing solutions and then looking at whether or not they're feasible. So that continues this conversation, and I know that an awful lot of patient groups would really, really welcome that. On the horizon scanning piece, the idea that you can have a joint horizon scanning has been put forward under the Benelux group of countries. And I know that people like Roisin Adams in the NCPE have been really leading that charge in terms of ensuring that there's a commonality and a common template for horizon scanning. Whether that would lead to what has been proposed there in terms of Vittoria's question, I don't know, but maybe Florian could actually answer that.
Okay, I'll go to Florian in a moment, Derick. I think that's a really important point that the politicians on this call could take up about the contact point in the Department of Health. Obviously, Department of Health is, shall we say, almost under siege at the moment between pandemics and all of the issues in hospitals and so on. But look, I think it's a really important point. We do have to continue. It's one of the points I keep making, that despite COVID, we have to make sure that, all of the other pieces of work continue insofar as it's possible at all, whether that's screening or the kind of points you've made, Derick. There's a point here from Michelle Levins. We won't have time to look at it. It's something I put questions into myself and the Commission, and that's the different number of tests, you know, the national heel prick test. I was amazed to learn that across Europe, it can range from maybe 2 to, I think it's 49 tests when a baby is born. I mean, I naively assumed it might be roughly the same in most member states. It's not. Incredible range. That's the kind of thing I think from a European best practice network and you know, discussion that, you know, we could look at. There's also a question, a lot of you have commented on research and the need for data sharing and so on. We've had a few questions on that. Now, there's a point from John Dunn. I'll just read part of it. Building on Bernadette's point, a soundbite that has stayed with me for some years is that collectively rare diseases are the third or fourth most common category of illness across the EU. And, you know, he goes on then to say, like, the implications of that, how, you know, not enough people working on them very often and so on. And he talks about to connect families in different EU member states. Again, it's about trying to learn from best practice, you know. Yes, and then final point, Vicky McGrath, why is reimbursement of therapies assessed based solely on the health impact? Surely as a civilized society, we should be looking on the whole person and the overall impact on quality of life. That's the point that Bernadette has made. Look, I'm conscious of time. I've given you a flavor of the questions there, and perhaps we'll finish by asking all of our contributors to make a final brief comment, but the conversation will be ongoing, that's for sure. Florian, I'll start with you.
Oh, no, it has been a great conversation, and I think it is something which also definitely all these reflections further help us in our internal discussion what we have to present in the review now of the pieces of legislation we are currently preparing. But as I said, this is only one element of the overall rare disease landscape. So while we are focusing now on this legislation, we should not forget the holistic answer we need in this policy issue, and there these kind of discussions are really important to bring the different angles together because it's so multifaceted. So thanks for that.
Well, thanks, Florian. I've no doubt people from this call will be in touch with you directly with some suggestions. There's no shortage of suggestions of how we move forward. Padraig, I'll go to you next.
Yeah, just briefly, and thanks again for hosting the session, Frances. It's been very productive. Look, whatever outcome, be it legislative or non-legislative steps that are taken in the short term, I just hope that we develop a process that's patient-centered, and I think that's the most important thing, because this is about life, quality of life, and I think your previous questioner there was right to highlight that. You know, at the end of the day, that's what the priority here is. But there is just one thing I'd like to add, maybe, and that's a number of weeks ago we marked National Rare Disease Day, and a number of speakers here were present at the time. And I suppose the commitment given by Oireachtas members on that day was that we would set up that cross-party Oireachtas committee. So that's something that we're hoping to do in the coming months, and hopefully we'll be able to get that rolling before the autumn. So thanks again. Thanks for everything.
Yeah, thank you, Padraig, for all your work. Rachel.
Yeah, so I think 2 points from me, one at the Irish level and one at the European level. At the end of the day, you know, the key point here is we're trying to ensure rapid access to innovative rare disease therapies for patients. At the Irish level, I think a solution is really trying to ensure that the process addresses the specific characteristics of rare disease therapy. So any efforts that can be made to address that, I think, will really have an impact. And at the European level, I think we need to bear in mind that for those rare diseases that don't currently have a therapy option, often the current development incentives and the standard innovation model won't actually effectively foster development. So I think we need to focus on what we can do, maybe all stakeholders coming together, some form of public-private partnership to try and find novel ways of actually addressing the lack of basic science that prevents therapies being developed in those areas.
Thanks, Rachel. Thank you, Rachel. And Derick?
Yes, just to pick up on that point, IPPOSI would be hugely supportive of a multi-stakeholder approach to the assessment of orphan medicinal products in Ireland, but also as more gene therapies and these advanced therapies come through, it's very clear that this needs a multi-stakeholder approach. And I think you mentioned it already, Frances, that whereas the state may think that the current legislation or the current process works when you have enough funding, it's actually that you need a bespoke process for orphan medicinal drugs, and a multi-stakeholder approach would definitely improve that. One final point about some upcoming events for rare disease community. So the Rare Disease Forum have 2 more events planned for this year. One is in early June, and that's going to focus on rare disease research. It's being organised and led by the Health Research Charities Ireland, and IPPOSI are leading the final event, and that's going to come up in Q4, and that's going to be on orphan medicinal products and indeed the digital space. So watch out for those. And just one final point, I think it's so important that I think what's clear is that rare diseases are not rare. And I think that one thing that struck me about the Northern Ireland Rare Diseases Action Plan was they were able to say that there's approximately 1 in 17 people in Northern Ireland have a rare disease. And I think that everybody on this call, everybody in Ireland actually knows somebody with a rare disease. So it's really, really imperative that a sense of urgency comes into and as a result of today. So thank you very much.
Oh, Derick, thank you. And I do see a comment here from Simone Boselli. She's talking about when Leo Varadkar was Taoiseach can address the European Parliament. He said, let's pool the buying power of 450 million people, to make sure that modern medicines are available at the same time in every country. That's certainly a vision we'd all like to have. And just a very quick point for myself, and that's about keeping innovation and supporting our pharmaceutical companies with innovation and keeping innovation in Europe and developing innovation. I just think it's so important because the pace of potential innovation for rare diseases at this moment in time has probably never been greater. So appropriately, final word to Bernadette, who's both a patient advocate and a researcher. Bernadette.
Thank you so much, Frances. And after every meeting, I'd love to see that there's some actions that come out of it. So at European level, from the rare disease community, I think we'd like to see that there's a hearing on the orphan medicinal products revision in the ENVI committee. We'd like to see a rare disease strategy being pushed for. We'd like to see the rare disease agenda being pushed forward by tabling written questions to the Commission and by ensuring amendments to reports are implemented to strengthen their rare disease and PKU dimension. It would be important to support us by engaging more MEP supporters from bigger countries to amplify our voice as well in the European Parliament. And I know that you take a specific interest in the area of carers, and I think European care strategy would help support formal and enable informal carers to care. And also attention should be paid to the crucial issue of transitioning from youth to adult care and from geriatric care from adult care as well for all rare disease conditions. So a care strategy should take this into account as well. And furthermore, a dedicated EU action plan on rare diseases would be warmly welcomed as advocated in the European Parliament in November by the co-chair of the SPKU, Billy Kelleher. And just my final point, and that is that patients and their families need to be listened to more. So we need to support them in the delivery of their message. We need to create opportunities to empower them to amplify their voice through advocacy capacity building, patient-partnered driven research and digital health infrastructure to support integrated care, and ultimately accurate data to ensure a holistic approach to care for all rare disease patients in Ireland and across Europe. Thank you very much.
Well, there's one strong advocate with a very clear list of demands, plenty to keep us going at every level, Bernadette. But look, my thanks to Florian Schmidt, Padraig O'Sullivan, Rachel Finnegan, Bernadette Gilroy, and Derick Mitchell for joining us with their expertise here this morning. I think it's been a great discussion. There's clearly a huge amount of work to be done in this area, but very worthwhile, and work that would really, make a difference to people's lives and to communities' lives. So well worth all of the efforts that we can all put in. Finally, my thanks once again to the European Parliament office in Dublin for working with me, cooperating with me to get this seminar online and for facilitating it. And again to Conor Glynn in my office, who did so much to facilitate today's session and ensured that it ran so smoothly. So look forward to ongoing contact with all of you on this topic. And thank you again for joining this webinar this morning, Rare Diseases in Ireland and Europe, Finding Innovative Solutions for All. Thanks again, everyone.
Thank you.
Thank you.